Okay, welcome everyone. It is 10 a.m. and I want to be respectful of everyone's time, so I'm going to get us started. I'm Nora Dunlap, Program Officer for the MAT Access Point project and the Center. Thank you so much for joining us today. This is in the second in a TA webinar series that we're offering our funded partners. And the MAT Access Point project aims to support startup and enhancement MAT programs throughout the state. So I'm going to keep this introduction brief so we can get right to the content, but a couple of logistics. The webinar is being recorded and it's going to be posted in the online portal along with the slides, so you can return to it at a later date or share it with other staff members. Additionally, please send questions at any time via the chat box found at the bottom of the webinar screen. We will sort through them and address as many as possible during question and answer period at the end of the webinar. It's a true privilege for the Center and the MAT Access Point project to sponsor this webinar, providing an in-depth look at contingency management programs, how they could be implemented in your organizations, and the impact they have on care and treatment retention. So I would like to introduce Dr. Richard Rawson. Dr. Richard Rawson, thank you so much for helping us host this webinar today and taking us through this important topic. Dr. Richard Rawson is an emeritus professor in the Department of Psychiatry and Behavioral Health Science at UCLA School of Medicine and a research professor at the University of Vermont. He received a PhD in experimental psychology from the University of Vermont in 1974 and has conducted an extensive portfolio of research on cocaine, methamphetamines, including projects on behavioral and medication treatments with brain imaging measures. He was a member of the Federal Methamphetamine Advisory Group for Attorney General Janet Reno, and during the past decade, he has worked with NIDA, SAMHSA, the U.S. State Department, the World Health Organization, and the United Nations Office of Drugs and Crime on international substance abuse research and training projects, exporting U.S. technology and addiction science throughout the world. He has published 3 books, 40 book chapters, and over 240 professional papers, and annually conducts numerous workshops, paper presentations, and training sessions. It's a great honor to have him here today to take us through this contingency management motivational incentives webinar. And with that, I will turn it over to you, Dr. Rawson. Thank you.
Okay, thank you very much for the introduction. Hi, everybody. I'm Rick Rawson. I'm currently sitting in Vermont, looking over the Green Mountains, which are currently white. But I spent 40 years in California, most of it at UCLA, and spent much of the 80s, 90s, and first decade of the 2000s doing work on stimulant addiction for the most part. Although my real original work in the 70s was with heroin addiction and testing out some medications and behavioral treatments. I actually didn't think I'd be doing this topic again anytime soon. I spent a lot of time in the 90s and early 2000s talking about methamphetamine and the behavioral treatments that are most effective with methamphetamine. And then, as you all know, we saw the opioid epidemic arrive in the early 2000s and sort of take over the first 20 years of this century. But unfortunately, we're now seeing the return of stimulants. On the East Coast, it's mostly cocaine. And for those of you in California, you've seen methamphetamine consistently for the last 30 years. And it's now making even more of a comeback. The current situation with methamphetamine in the US is that we're seeing extremely high potency methamphetamine coming across the border. It's made with a new formula. It's called the P2P method, which produces a more potent form of methamphetamine, and it's being made in very large quantities, and the cost is much lower than it has been for many years. Actually, the cost is lower than it's ever been. The border agents are seizing 10 to 20 times the amount they did a decade ago, and it's never been purer, cheaper, or more lethal. Just to make a bad situation worse, starting about 5 years ago, we started seeing methamphetamine be mixed together with fentanyl. Now that's been a game changer. The addition of fentanyl to methamphetamine sort of changes all the rules of how we have to deal with people with methamphetamine use disorders. This gives you some indication of the relationship between methamphetamine availability and the deaths associated with methamphetamine. As you can see, the blue line are the number of meth seizures. The red line is the rate of deaths. And if you notice, beginning in about 2014, the slope of the line for deaths is increasing. This is the overall drugs and death picture. And as you can see, starting 20 years ago, the rates are very low. The green line cutting across the page is prescription opioid deaths that gradually increased from 1999 through 2017. Beginning in 2010, the gray line shows the increase in heroin-related deaths. And then in 2014, the blue line that spikes up is the deaths associated with fentanyl. Now, if you look, the bottom two lines are deaths associated with cocaine, which have increased dramatically since 2014, and the deaths associated with methamphetamine, which have increased dramatically since about 2014. Now, when the medical examiners record these deaths, it's not always clear what the drug is that produces the fatality. And with many of these stimulant deaths, cocaine and methamphetamine, although their methamphetamine or cocaine are on board, it's not clear whether it's that drug or the fentanyl that's been included that's the cause of death. If you see on this shows the blue line is the rate of overall methamphetamine associated with deaths. In the left panel, the dotted line are the methamphetamine related deaths with any opioid. And then the dashed line at the bottom is that's going up very sharply are the deaths associated with synthetic opioids or fentanyl. And so we think that a lot of the big spike in methamphetamine associated deaths is related to fentanyl, although not all. I mean, the fact that the methamphetamine is much more potent also is associated with pure methamphetamine deaths, which typically occur as strokes or heart attacks. Methamphetamine does not suppress respiration, so those deaths that are from people stop breathing, those are typically the fentanyl that's causing the death, but you can get death from methamphetamine and cocaine. This gives you a little bit of an indication of the fact that the patients that we're seeing for opioid use disorders are starting to show increased rates of methamphetamine use. This is from a study in St. Louis. It goes through 2017. These people have reported out more recent data as of 2019, showing it's up to about 45% of the opioid users who are coming in for treatment with buprenorphine and methadone. About 45% of them have methamphetamine on board. I did a bunch of training in California over the last year. In San Diego, one of the sites that I did training reported 60% of their buprenorphine patients were positive for methamphetamine. Here on the East Coast in Vermont and New England, it's about 50 to 60% that are associated with increased cocaine use. So we're seeing in a lot of the patients that we're treating for opioid use disorders, we're seeing a lot of stimulant use. And in talking to people in OTPs, opioid treatment programs, methadone programs, and in primary care settings where people are treating people with buprenorphine, we're seeing an awful lot of those patients using stimulants, either cocaine or methamphetamine. Oops, sorry. Okay, the clinical challenges with stimulant-dependent individuals are in many ways different than what we see with opioid users. If those of you listening have done most of your addiction treatment with opioids, treating people with stimulant use disorders is going to be different. There's some significant differences. Although the very first bullet point, overdose death, is one that I've never had on my slides for stimulant dependence. Certainly, historically, people did die from cocaine and methamphetamine overdoses, but it was relatively unusual. But now with fentanyl as part of the ingredients of the methamphetamine and cocaine that are sold, overdose death is getting far more frequent. And as I said, it really is a game changer. I was doing a talk in Maine 2 days ago about this with a group of treatment providers, and we were talking about their sort of the rules of their treatment programs and when they discontinued patients from treatment and who they kicked out of treatment. And I tried to make the point with them that kicking people out of treatment in 2019 with fentanyl is as available as it is really a very dangerous thing to do. That finding ways to work with patients without kicking them out of treatment, whether it's residential treatment or on buprenorphine or methadone, really is essential. We have to find alternatives to kicking people out of treatment, because more and more frequently kicking people out of treatment really is giving them a death sentence. That they, if they have been on a medicine like buprenorphine or methadone, you take them off those medicines, they're going to relapse, and their relapse is likely going to be with fentanyl. Similarly, if you're treating them for methamphetamine dependence, they're in your residential treatment program, and you kick them out and they're not on buprenorphine or methadone, they're at extremely high risk to overdose from the fentanyl that's in the methamphetamine they use. So I would encourage you to review your treatment protocols and find alternatives to kicking people out of treatment. It really isn't, it really can't be defended at this point. And there's many lawsuits currently underway of family members of overdose patients suing treatment providers who kicked their family member out of treatment, followed by a fatal overdose. So both for legal reasons as well as for ethical reasons, we're now at a point where we have to find alternatives to kicking people out of treatment. Other clinical issues, unlike opioid users who generally know they're addicted when they wake up and they're going into withdrawal, many stimulant users don't recognize they're addicted. I did a survey here of 25 patients on buprenorphine and methadone who were using cocaine. All 25 really didn't see the cocaine use as a problem. They view that they're opioid users, they're addicted to opioids, they're on medicine for their opioid use, and their stimulant use is sort of just a recreational activity. It really isn't an addiction problem to them. And so the first challenge you have is you're working with a group of individuals who don't see the drug use as a problem. They're obviously then they're ambivalent about stopping if they don't see it as a problem. Generally, they say the only one who has a problem with this is my doctor, who says he or she can't prescribe buprenorphine for me if I'm going to continue to use. The stimulant use is associated with impulsivity and poor judgment, cognitive impairment. The real hallmark of stimulant dependence in the treatment of individuals with methamphetamine and cocaine dependence is anhedonia. They have their first 6 months, 4 to 6 months, are the dopamine system has been downregulated. They're not able to experience pleasure particularly well, and they often relapse around the fact that they just don't feel right. They just don't feel anything enjoyable in life, and so that often leads to relapse. Meth users particularly have hypersexuality and violence and psychosis. Psychosis is very common with meth use, generally paranoid, some kind of paranoid psychosis. They have a powerful Pavlovian craving response that is really much to do with how they lose control. when they're trying to stay sober. They're hard to retain in outpatient treatment, and they have elevated rates of psychiatric comorbidity. The retention issue is the ball game. If you can retain them in treatment, they generally show progress and make progress in dealing with their substance use disorders. But if they don't, they get worse. For those of you who have ever wondered about what happens to people when they drop out of treatment, they don't get better, they get worse. And with fentanyl being the drug they're now using, their getting worse can often mean that they are at very high risk for overdose death. Injecting of these drugs produces the highest risk of overdose death. And so if you get patients who are injectors, if they're meth injectors and opioid injectors, these are people who are a real priority to getting them into treatment and getting them on medication. We know that if people are on medication, buprenorphine, methadone, naltrexone, they're at much lower risk to overdose and die. Even if they use, they're at lower risk to overdose and die. So getting them on these medicines is truly life-saving. I spent 45 years doing this work, and my orientation to addiction treatment was always to help people get into recovery and help them prevent relapse and be productive in their lives. But now I think we have to go step back one step before those issues, and we really have to be concerned with keeping patients alive. Dead patients don't recover. And so it's important to realize that your policies and practices have to focus first on getting people into treatment and keeping them in treatment, even if they're not, doing 100% of what you're recommending for them to do. It really has moved the whole discussion about harm reduction much more into the mainstream of our treatment rationales for treating people with meth and opioids. As I mentioned, fentanyl is now showing up everywhere. Here in Vermont, in all of the drugs on the street, heroin, cocaine, methamphetamine, all of it has fentanyl in it. I don't think it's as bad in California as it is in New England. It really, in the US, started showing up in New England first. I'm still involved with California doing the hub and spoke project that is occurring in California. And it's my impression that although fentanyl is showing up, it isn't in the same degree as it is in New England. It's likely to get much worse. So as you're anticipating that your patient population needs, this issue of getting people onto treatment quickly and without having them on waiting lists is really essential. The practice of methamphetamine and fentanyl use is something that's now being called goofballing, that people, we called it speedballing with heroin and cocaine. One of the things that's different though is this isn't people mixing the drugs themselves. It's not that the user says, I'm gonna buy some heroin, I'm gonna mix it with meth and then inject it. It's already come mixed. It's the drugs they're buying on the street are already mixed by the drug traffickers. One thing that I think should be considered by individuals, people treating meth users, even if it's a residential treatment program or an outpatient drug-free treatment program, providing meth users with naloxone, I think should be considered, because many of them don't have a lot of experience with opioid use. And if all of a sudden their meth starts showing up with fentanyl in it, they may be at very high risk for overdose. Okay, let's talk a little about treatment for these individuals. The behavioral treatments for individuals with stimulant use disorders have about a 35-year history. We started doing a lot of work with these people in the 1980s. Started with cocaine primarily in the early 80s. In California and the West Coast and Hawaii, we were seeing meth by the late 1980s. And then the Western US developed a significant methamphetamine problem. In the East, it stayed mostly cocaine, but these two stimulants have been although they have geographic differences, they've produced, great need for treatment services over the last 30 years. One thing I should say is the evidence on treatment of cocaine use disorders and methamphetamine use disorders, or ATS, amphetamine type stimulants, the behavioral research has been pretty much identical. That is, if you have a treatment that's effective with treating meth users, it's also going to be effective in treating cocaine users, and vice versa. So when we look at this whole area, we really look at behavioral treatment for people with stimulant use disorders, not cocaine or amphetamine. Medications may be different. I'll talk about that toward the end. But in the last few years, there have been a number of large analyses of the treatment literature. In medicine now, more commonly, we're seeing these analyses called meta-analyses, where teams look at large groups of studies. They're no longer looking at one study or two studies. They're looking at big batches of them. This is a meta-analysis on your slide, on your on screen, of a meta-analysis that was released, published last December by a group from Oxford University in England. This is a group that isn't particularly focused on substance use disorders, but they're focused on doing these big meta-analyses on all areas of medicine. And this one is their results of their study on comparative efficacy and acceptability of psychosocial interventions for individuals with cocaine and amphetamine addiction, a systematic review and network meta-analysis. Now, if any of you are researchers and you're familiar with meta-analyses, you may have the same frustration I often have, which is that most of these meta-analyses kind of say, well, nothing really works all that well. This may work a little bit better than that, but it really is kind of all gray and nothing really stands out. Well, that's not what these guys, this team, found for amphetamine use disorders and cocaine use disorders. They analyzed 50 studies, included 7,000 participants, looking at 12 different psychosocial interventions for cocaine and amphetamine addiction. Their results were the combination of contingency management and community reinforcement approach was the most efficacious and most acceptable treatment, both in the short and the long term. Very definitive conclusion that contingency management and CRA were the two things they found to be most effective. About a decade ago, another group put together by the World Health Organization did a meta-analysis of the psychosocial interventions for cocaine and stimulant amphetamine related disorders. They looked at 27 different studies with about 3,600 participants. Their conclusion were the comparison between the different types of behavioral interventions showed results in favor of treatments with some form of contingency management in respect to both reducing dropouts and lowering cocaine use. About a month ago in The Lancet, a review article was published by an Australian group looking at the same issue, responding to global stimulant use challenges and opportunities. Their conclusion was psychosocial interventions other than contingency management have weak and non-specific effects on stimulant problems, and there are no effective pharmacotherapies. So those are three pretty definitive analyses of the literature that we have collected over the last 30 or 40 years on the behavioral treatments of stimulant use disorders. Rarely have I seen a set of literature that's so consistent about the conclusions that contingency management is really standalone as the most effective treatment approach. Unfortunately, we've known that in the US for 25 years. We've had lots of studies on this. The Clinical Trials Network, NIDA's Clinical Trials Network, has done some big studies, but we've had trouble getting people to implement it. And that's what I'm going to talk about in just a minute, is some of the issues around if this works so well, why aren't people using it? And that's really the issue. For me personally, it's not unlike when I used to go out and do talks on medication-assisted treatment back in the 80s and 90s, and would talk about methadone. And at the time, we were using LAM, and we had using naltrexone, and then buprenorphine came on. And I would go out and talk to audiences in California, and many of the clinical staff would be like, yeah, okay, we understand there's all this data, but we don't believe in medicines, and so we're not going to use medicines. We're going to keep doing what we're doing. I get the same feeling now with this contingency management stuff. The data are overwhelming. The science is overwhelming on this, and yet we still aren't seeing people use this, except for in the VA. The VA has actually implemented contingency management in many of its settings. I don't know, to be honest, how extensive it is. I believe this is a nationwide dissemination. This paper calls it that, but I'm not sure if really, literally every VA is using contingency management. The ones I've talked to, the one here in Vermont, the one in at the West LA VA, I know they are, and it's sort of their routine treatment for patients with stimulant use disorders. Now, the VA system is well suited for this because they have their own economy. That is, if patients come in for cocaine, people can earn vouchers and other reinforcers, and they can go to the canteen and cash them in. So it's all their own economy, which is one of the challenges out in the rest of the world. But if you would like, there is a team, Dominic De Philippis at the University of Pennsylvania really is leading this charge in the VA, and he's a really great champion for this, and is more than happy to talk to people about implementing it. Ditto with our Carla Rash at the University of Connecticut. She also is doing a lot of work with this. So I've talked about what a wonderful thing this is. Well, what exactly is contingency management? Well, if you, any of you took Psych 101 and you remember B.F. Skinner, the behavior of organisms, the use of positive reinforcement to modify behavior, that's what contingency management is. It's using a technique employing the systematic delivery of positive reinforcement for desired behavior. In the treatment of methamphetamine dependence, vouchers or prizes can be earned for submission of methamphetamine urine samples and other desired behaviors. It doesn't have to simply be focused on drug-free urine samples, but that's been the most common application of contingency management in the research studies. Very simple. If you want to increase retention in treatment, if the patient attends treatment, they can be given an incentive that increases retention in treatment. If you want them to reduce their drug use as measured by urinalysis, if you give incentives when they turn in negative samples, you'll get reduced drug use. It's that simple. We use incentives in society, for all sorts of things. We give our kids prizes for good grades. We give trophies for people who achieve certain benchmarks. Workers get bonuses for performance in some cases. We've just never used reward, particularly in the treatment of people with substance use disorders. The basic principles are you have to have a behavior you can monitor and measure. It can't be something like an attitude or you want people to show better motivation. You have to actually have a measurable behavior to link the incentive to. You provide the incentive when that behavior occurs, and you remove the incentive when the behavior doesn't occur. A couple of specifics notes are, we never give money. Money is never given out because money is a Pavlovian trigger for people with stimulant use disorders, virtually all of them. If you plop a $20 bill into their hand, their heart rate will increase, their skin temperature will decrease, and they'll start to experience craving as a result of the fact that money is often a trigger for stimulant use disorders. The other specific issue is you have to be able to do this at the point of where you collect the behavior. For example, if you're making drug-free urine samples as the behavior you're targeting, when the individual comes in and they give a urine sample, and it needs to be able to be tested at the spot, and the reward needs to happen immediately. So it is a challenge for some treatment agencies who send all of their urine samples out for analysis in a lab. You need to be able to develop point of care testing where you're able to get immediate results. Just some of the data on this. Steve Higgins from actually here at the University of Vermont did one of the first studies in the early 90s where he looked at use of incentives with individuals in cocaine treatment. Part of what he showed was this is mean continuous abstinence during the first 24 weeks of treatment. The dark bar is the individuals who receive incentives. The gray bar is those who receive standard counseling. And you see over the course of the first 24 weeks, and then he breaks it into the two 12-week chunks, you see the those people who receive incentives are much more likely to maintain continuous abstinence. John Roll did a study with the Clinical Trials Network on methamphetamine, published in the American Journal of Psychiatry in, I think, 2006. 113 participants, 12 weeks of treatment. They all got behavioral treatment, the matrix model. In addition, half of them got contingency management, half of them did not. And the results were those receiving contingency management, in addition to usual treatment, submitted more negative samples and were more likely to be abstinent for longer periods of time. He used a methodology called the fishbowl method, which was developed as a way to try to stretch the money out. In Higgins's study, the first one I mentioned, individuals would receive vouchers. They give a urine sample, they'd earn a $2.50 voucher. It was a little slip of paper, said this is worth $2.50. If they gave a second urinalysis that was drug-free, a consecutive one, they got another one. And if they gave a third one, they'd also get a $10 bonus. And over time, the value of the incentives went up. And in Higgins's studies, people could earn somewhere in the neighborhood of $500 to $600 over a 12-week trial. So it was a fairly large dose of incentives. This fishbowl method actually is used to try to stretch the money. That is, they're using, in operant conditioning terms, a variable schedule of reinforcement. People will draw a slip of paper out of a fishbowl or a box or something, and some of them just say, good job. Some of them have a small value, $1 to $5. Some of them have a large value, 20 bucks, and some they refer to as the jumbo, which are worth $100. In this model, generally people make somewhere in the neighborhood of $200 to $300 over a 12-week trial. I do want to mention, though, that I know a lot of places have tried doing contingency management with very small vouchers, $10 grocery coupons or gas coupons or some, very small kinds of incentives, using the spirit of contingency management, but trying to do it with very low magnitudes of reward. I think you need to think about how buprenorphine would work if you gave everybody 2 milligrams, that it was, you said, well, I know this medicine works, but we really don't have enough money to give them the dose that's in the literature, so we'll just give them a little bit and hopefully that'll work. Generally, it doesn't work. There are exceptions where people can get some good effects using very low levels of reward. But in general, the reward, you're trying to counteract a very powerful addiction with stimulants. So to really do contingency management in a way that's consistent with the literature, the magnitude of reinforcement has to be significant. I mean, we're talking about several $100 maybe over a 12-week trial as an absolute minimum. Below that, you still might get some effects, but you're not likely to get the effects that you see in the research studies. This is the data from John's study, John Roll's study. This is mean number of negative samples over the 12-week trial. And the contingency management gives you about 50% more negative samples than treatment as usual. This shows you the retention rate across the 12-week trial, with the incentive showing a much higher rate. This is a study that I did with the team at UCLA. We published in 2004. This one had 3 groups. These were all cocaine or meth users. They came in for a 16-week trial. They came in 3 times a week. They either got cognitive behavioral therapy, contingency management, and this was using the model that Higgins used, where they could actually earn $500 or $600, or they got a combination of contingency management plus cognitive behavioral therapy. We gave them both. The results were that this is on the y-axis. You have the mean number of stimulant-free urine samples. CBT, you got about 15 samples drug-free. And in both of the contingency management groups, it was about double that. You got close to 30, and there was no difference in the additive effect. So both of those are highly statistically significant. And this is about the same thing on the percentage of people who achieved 3 consecutive weeks abstinent from stimulants. Again, about double in the 2 contingency management groups over the CBT group. We did a similar study with comparing contingency management and cognitive behavioral therapy for people on methadone maintenance who were using cocaine. There was a big problem in the 90s. It was really devastating the methadone clinics at the time. We didn't have any treatments that worked, so we tried, this study had 4 groups. Everybody was on methadone maintenance for their opioid use disorder. One group just got standard methadone treatment. One group got methadone treatment in contingency management. One group got methadone treatment in CBT, and one group got all 3, methadone, CBT, and contingency management. This gives you a picture of the results. The methadone maintenance group gave 11 drug-free samples out of 48 potential. The CBT group gave about 20 samples. And the 2 contingency management groups, significantly more. Basically replicating the earlier study, only showing that the contingency management with patients on methadone really could work quite well. And these were really pretty hardcore opioid users. They were in a inner city clinic. They used opioids for a long time, smoked a lot of crack. And we were really surprised at how well the contingency management worked. And the patients would talk about the fact that they really weren't all that interested in, but the contingency management gave them a reason to stop, and it gave them a rationale. And once they actually stopped, they could see some of the benefits of stopping. And so many of these treatment benefits carried on beyond the discontinuation of the treatment study, and we were quite impressed with the robust effect. There have been a bunch of other studies. The Clinical Trials Network has a study, a big one on looking at stimulants, reducing stimulant use of people on methadone maintenance treatment, and several other similar studies. From 1991 to 2014, 176 controlled studies in peer-reviewed journals were reviewed, with 151 reporting statistically significant effects, 86%. Very few treatments in substance use disorder literature have that kind of track record of effect. Buprenorphine and methadone do, but those are about the only other 2 that have such a robust literature supporting them. Okay, what are some of the keys to implementing contingency management? First, the goals are to enhance treatment and facilitate recovery. And I would now add actually one before that, which would be to reduce overdose death and reduce dropout of treatment. I just saw data presented by NIDA last week in a webinar, or actually it was Monday of this week in a webinar, where they presented dropout rates of patients on buprenorphine. And for those who are using cocaine or methamphetamine, the dropout rate of buprenorphine treatment is about double, almost exactly double that among patients who are not using cocaine or methamphetamine. So to the extent dropout of treatment puts them at higher risk for overdose death, I would say that certainly this contingency management treatment will save lives if it helps retain people on buprenorphine or methadone better than without that treatment. So these incentives, I mean, contingency management and motivational incentives are the same thing. They're the same exact technique. I think NIDA thought that the term contingency management was too technical and off-putting, so they decided to call them motivational incentives. Unfortunately, for those of you who do addiction treatment, motivational interviewing is a well-known technique. And it makes it confusing when you start talking about MI, whether you're talking about MI motivational interviewing or MI motivational incentives, but you get the idea. The staff that have been involved with delivering contingency management have generally been very positive, although initially that was a big source of resistance in the VA studies where they have it implemented now, and in some of the other NIDA implementation trials. There was often an initial resistance among clinical staff that we shouldn't be paying people to not use drugs, that this was somehow not using their internal motivation, and that it was sort of like cheating, that we were using these rewards to incentivize. I have to say, having done this for 45 years, my experience is if you do something and it works, you a little bit less about, whether they're doing it for the right reason or not. It definitely is very effective. There's a group doing this in a clinic system in Wisconsin pretty extensively, and they've talked about how much it improved the general clinic environment, being able to add these positive reinforcements to the treatment plan. The rationale, as I mentioned, is real basic operant conditioning. Behavior occurs if the consequence is positive. If it's a reward, the behavior is more likely to occur again. We certainly know how to use punishment in treatment. We've done that for 50 years, 60 years, kicking people out of treatment, doing all kinds of punishers, but we have not probably maximized the extent to which we use positive reinforcement in treatment. This is just talking about the difference between positive and negative reinforcement. Positive reinforcement really has the benefit of not only being able to use it to change specific behaviors, it generally keeps people coming back. And so it's good for retention just in the general treatment environment. So you have to individualize it. Different people want different rewards. That's why we often use vouchers that people can trade in for different stuff. Or if you're going to use a model where you actually give people like coupons or gasoline vouchers or vouchers to Walmart, or that you have a range of them, because some people will, that you need to make sure that whatever you're using as a reinforcer, that it actually is reinforcing to that specific patient. So we do try to have people make sure that there's a range of rewards. And this is, I mean, we have used rewards in treatment, and in the 12-step programs, people get chips or cakes, or they get some kind of acknowledgement of their achievement. That's simply what this is. We did a study at UCLA back in the 90s. We were doing it in a couple of private clinics. These were patients who had plenty of resources. They were not indigent patients. They responded equivalently. That is, these rewards take on not only a literal value that they can use to buy stuff and trade in for food or gasoline or whatever, but they have a symbolic value of the patient having achieved something. And so the value is certainly important, and typically for patients who don't have or have challenges with material things, they're really life-saving and can really be essential. But even beyond that, it doesn't have to be only people who are really struggling. It can be people. Rewards work for everybody. So the behavior has to be measurable. The reward has to be provided when the target behavior is demonstrated. And when the behavior doesn't occur, either the person doesn't show up or they give a urine that's positive for drugs, they don't earn the reward. They're not punished, they're not chastised, they just don't earn the reward. And I think it's important as you're delivering these that if you're giving vouchers, they can either cash them in immediately if that's what they choose to do. If you're giving them a set of vouchers and they can earn $5 a voucher and they get a couple of them and they want to use $10 to get a gasoline card or a voucher at Target or something, they can do that as they want. Some people will like to total them up and just have them continue to mount up and then get a larger reward. Making it as individual as possible is really important, so that the reward is something that's rewarding to the person. So this set of slides now walks through the specific principles. First, find a behavior that is observable, measurable, and relatively easy for the patient to achieve. You want them to be rewarded. This often comes up if you use the fishbowl method and you've got all these slips of paper that say good job and they don't really earn anything tangible initially. You often people will start with the first month or the first 2 weeks where they have a reward schedule that's more rich at the beginning, because you want people, if they give a negative urine sample, to earn something right away. You don't want them to keep getting, good job, and they don't actually earn anything, because at the beginning, they really need to experience the reward. Then you can increase the delay in the reward, or the number of good jobs they earn. The population, you can use it with all patients, but in general, we recommend that you use it with patients who actually need some additional attention. This is an intervention that certainly in a buprenorphine practice, lots of patients are doing well. They don't need contingency management, but those who are using stimulants and who don't seem to be able to stop, that may be the group. You may want to pick only a subset of that group. The women or the pregnant women or the younger patients or some specific population that you want to apply this with. It doesn't have to be with everybody. The reinforcers I've mentioned, they need to be flexible. The magnitude matters. You can't get huge behavior changes unless the magnitude is sufficient in providing the reward for patients. The frequency, people need to come in. This is a big challenge for the patients on buprenorphine who are only coming in once every couple of weeks or once a month or even once a week, that they may not be in contact often enough to earn the reward so that they're able to show that it reduces their stimulant use. So this is something that needs to be considered. Immediate reward is important. How long do you do this? There have been no studies on the necessary duration. I think the answer to this is going to be similar to how long do people need to stay on buprenorphine or methadone. Some people need to stay on for a long time. Many may need to stay on. And the same may be true with the use of this intervention. We don't know. There have been no systematic studies of the length of time. We do know that it works. We do know the group, when I was in Wisconsin talking to them, they said they have some people that have been on vouchers for 6 months, and they still find them extremely valuable. As I mentioned, there is this strategy called the fishbowl where people have different value slips of paper and they draw them. And this is a way of making your resources go further, although there's a limit to how much you can stretch that out. Oftentimes what people will do is if you come in and you give your first urine sample and they give you the voucher, they may give you a small prize right away. And as you start developing it over time, maybe after you give 3 consecutive urines, you get to draw twice from the fishbowl, not just once. And if you go 2 weeks of consecutive abstinence, you get to draw 3 times from the fishbowl. So there's all kinds of ways that people try to reinforce extended abstinence, not just individual urine sample results. So the challenges, cost of the incentives, obviously that's a big issue. On-site testing is necessary, and in some places counselor resistance. Although I have to say that in the last 6 months as I've been doing these talks, there seems to be much less resistance to the idea of this than there used to be. Used to be this was like, this is wrong, we shouldn't be doing this. I think as you see these stimulant users and you see how severe their disorder is, and if this works, I think people are being more pragmatic and saying, all right, well, if it works, let's give it a try. There was a concern that maybe if people are doing this fishbowl thing, that it looks like a lottery and it may help trigger more gambling. In all the NIDA studies, they have some measure of other outside gambling and have not seen any relation to increase of gambling. And again, this gets at the internal versus external motivation. And I would argue at this point, if we've got something that works, regardless of what the motivation is, it's something that certainly should be considered given the efficacy of it. I mentioned that the VA has actually studied how to get it implemented and has successfully implemented it throughout the VA. Here's some resources, some websites, and I think the slides are going to be made available to you. You'll be able to go back and review these. There's some self-paced courses that are really useful on how to go about setting up contingency management or motivational incentives in your treatment setting. And these are 2 new alternatives. These are apps that have been developed. One is called Reset, which is developed by the group at Dartmouth, and has actually been the first app that's been FDA approved for use in treating substance use disorders and is now reimbursed by insurance. This is one where you actually use the app to deliver the reinforcers. People earn credits that they get on a limited credit card where you can use it in certain stores and other specific places. Dynamic Care is another service that is also an app-based service to deliver contingency management. I think these 2 may be particularly useful to clinicians working in primary care using buprenorphine with patients who don't come in all that often, but you want to try to use contingency management. It can be set up that the patient goes to a laboratory, gives a test, the result is sent back immediately to the into the app, into the website, and the reinforcer is transferred onto their card. And it can all be done remotely without them having to come to the clinic. Those are some of the basic elements. I did mention that I would talk briefly about medications. There has been a 30-year effort of examining medications for stimulant use disorders. The group at UC San Francisco has just published a couple of studies on mirtazapine, which is an antidepressant, which probably has the best evidence to date of any medication. And Phil Coffin over at UCSF and his colleagues certainly are the ones, if you were interested in getting information about the work with mirtazapine. There's also been some work with bupropion or Wellbutrin that has some evidence of usefulness, but certainly neither of those medicines has anywhere near the robust effect that we've seen with contingency management. And on the webinar on Monday, Phil Coffin was saying, even with the best medication that he's seen, this mirtazapine effect, it's going to need to be used with contingency management to produce the kind of reductions in stimulant use that we think we need for clinical progress. So I'll stop there. If we don't get to answer all your questions in the next period of time, those are my emails. I do a lot of answering questions over email. I'd be happy to give you additional information or answer questions if anybody wants to send me an email. So I will stop there. I did see some questions pop up in the session, so I'd be happy to answer questions now too.
Thank you so much, Dr. Rosson. There were two questions that came in. One might be a little bit easier than the other one, so let me start with that one. Is it significant who is providing the reward, whether it's medical staff or the therapist? Is there any difference?
Well, I think that it's, well, I'll just tell you how the people do it in Wisconsin. They're using it in a treatment program where they're doing behavioral treatment, cognitive behavioral therapy groups, individual sessions, and there they do it as part of one of their groups, and the therapist delivers the contingency management. There haven't, as far as I know, there haven't been any studies of that, but I don't think this would work as well if it was, for example, delivered by a vending machine. I think getting the interpersonal reward as well, the praise and the praise from both the staff person as well as from other patients magnifies the reward value. So you want to try to make it as big a deal as you can because you want it to be as reinforcing as it can be. So, you know, to the extent it's possible, you'd want it delivered by someone the patient really values. Their doctor, I mean, would be great, but I know that that's not practical. But you know, just try to do it in a way that tries to magnify the value of the actual voucher with social reinforcement as well.
Wonderful, thank you. And just a reminder, we are posting the recording of this webinar and the slides in the online portal, so they will be accessible. Another question that came through is about funding for these programs. What about funding that has limitations, like Medi-Cal only allowing a max of a 30 non-cash reward for patients? Any suggestions on funding or some of these limitations?
Well, one of the reasons I was glad that you asked me to do this is that I think that in many settings, it's going to take a while for people to figure out that part. I don't think there's one answer for that. In some parts of the US, the State Department of Healthcare Services, DHCS in California's case, has made money available through the block grant and through various grants that they give to organizations to use for contingency management. In other places, here in Vermont, that we have a bunch of our buprenorphine clinics are attached to hospitals, and the hospital has provided them with a fund to do contingency management. I ran a clinic in Los Angeles that was for women, prenatal women who were pregnant and who had small children, and we went out and got donations from the community to support. We put together like a pantry of a closet that had all kinds of stuff that they could earn with their giving drug-free urine samples, stuff for themselves, stuff for their kids, and that seemed to work out. So I think that is the biggest obstacle right now, and it may need to have different solutions in different places. But I certainly think, I know in talking to DHCS about their next round of federal money from, they may, as they're doing with your access points grant, and as they're doing in the emergency departments where they come up with special funding I think they may have money available that people can use for contingency management purposes. But it is a challenge. That's the biggest obstacle right now, is figuring out where to get the money and how to get enough money to make it clinically meaningful.
Thank you. Another question, you mentioned that kicking out patients is not the direction to go. So do you have any suggestions on some alternatives you've heard that might be more in the harm reduction realm, and some suggestions?
Yeah, I mean, it's been a big issue in among a lot of the docs providing buprenorphine treatment, if that's what we're talking about, that they're worried that the DEA or somebody is going to come and prosecute them for writing buprenorphine prescriptions to people who are active stimulant users. We actually had a speaker here in Vermont from DEA. They talked about what they're interested in is to see that the clinician, that the prescriber is addressing the stimulant use, not necessarily that they've cured it or that they've, documented that there's no more stimulant use, but that they're trying to develop interventions that will help reduce the stimulant use. It's not as though they're just operating oblivious to the stimulant use, and that's sufficient for the DEA and here in Vermont, the medical board. I think that's generally been the attitude that I've heard. I've done this talk around contingency management now in 14 states, and that's the response I get, which is that the idea that you're going to be prosecuted for writing a buprenorphine prescription if somebody is using stimulants, that's not really a risk, as long as you're making an attempt, having the person come in more often, having them see a counselor, having them get a contingency management program, that you're actually doing something to address the issue and not just ignoring it. The question though of the harm reduction strategies, I think that in general, a lot of the prescribers I talk to try to have the patients come in more often. They do use their motivational interviewing skills, and we try to get everybody working with these patients to be familiar with motivational interviewing. Talk to the patients about reducing their use, talk to them about how they can minimize what other activities they can be involved with, and looking at some of the why, what they're doing, where they're using, that kind of stuff to help the patient think through and try to reduce their use. Doing a lot more counseling, though, doesn't necessarily do anything. In fact, the 25 I spoke to here in Vermont, when I said, well, what about more counseling? Would more counseling help you stop using? Pretty much they unanimously told me no. And in fact, if you make me go to counseling too often, I'm more likely to drop out of treatment than I am to reduce my stimulant use. So the idea that you try to jam them up with a lot more counseling probably is not going to be useful. Other harm reduction strategies I just wrote a paper on harm reduction with stimulant use disorders. Boy, we don't have as much as we do in the area of opioid use disorders, but getting them to, if they're injecting the stimulants, talking to them about using some non-injection method of use rather than continuing to inject. The general harm reduction strategies are important, but talking to them about your concern about their stimulant use, presenting them with some of what you think the medical concerns are that you have about their stimulant use, and providing them with support for staying on, coming back, getting their buprenorphine. All of that needs to continue so that them dropping out of treatment is the worst case scenario.
Thank you. There's two more questions that came in, so I'll try to ask them briefly. One is, are any programs using exercise for stimulant use reduction?
Hey, that must be one of my students. No, we published some data back in, well, it's been about 3 years now. The last study I did when I was at UCLA full time was an exercise study. And we found in one study, not 176 like with contingency management, one study so far, we got good results from exercise. We found that it it helped in a whole bunch of ways. Mood regulation, big improvement in anxiety and depression scores. Much better health measures, reduced stimulant use, significantly reduced stimulant use over a 6-month follow-up period that we had. And it was, the patients really liked it. They were really, their response to it was good. Now, not everybody will continue exercise. I mean, our patients are no different than we are in terms of, you know, exercise. Everybody knows exercise is good for you, but it's hard to stay on track with it. But to the extent that you can get people to exercise, it is an active intervention. It's not just a good thing to do. It definitely, we measured D2 receptors in the brain pre-post. We found that exercise caused a speeding up of the recovery of the dopamine system as a result that's been damaged by methamphetamine. So exercise is a real thing. And if I was developing a protocol for treating stimulant users, I would certainly have exercise as part of it. If people want those studies, they can send me an email and I'll send them the results.
Thank you. And Stalent Health also here in California said they do CM and they have a group near them that's a running club for women in recovery that they refer patients to and seen positive response. And last question, any theories on why individuals with substance use disorder respond to CM versus the general population, perhaps delays with emotional maturity due to heavy drug use during developmental years? Question mark.
I don't know. I mean, I think that contingency management will work with any population. I mean, it's positive reinforcement. I mean, positive reinforcement works with, you know, executives earning zillion-dollar bonuses and, you know, anybody. I mean, and including non-human species where we use rewards to teach dogs how to do things. I mean, the use of rewards is a universal principle. I do think that with patients with stimulant use disorders, they're particularly well suited because the more cognitive therapies are difficult for them to process because of the effects of the stimulants. I think that memory is a big problem, and so if somebody comes in after being you know, out there using methamphetamine for 3 years and they come into your outpatient program and you start doing a lot of CBT with them, a lot of it goes in one ear and out the other ear. They're just not able to retain it. The behavioral strategy of contingency management, when you talk to the patients about it, what they say, what these folks that I've talked to say about it is, when I'm out there trying to not use, it gives me something to hold on to. I know that in 2 days, I'm going to go in the office, I'm going to give a urine sample, and if it's drug-free, I'm going to get my voucher, and I'm really counting on that voucher. And that, it not only gives them a strategy for not using, it gives them the incentive to not use, which is one of the things that comes and goes with people, as they're, you know, attempting to stay drug-free. I mean, one day they're really motivated, the next day it's like, you know, maybe a little bit won't hurt. But if they can hold on to this idea of earning the voucher, of earning the reward, that seems to be a tangible thing they kind of cognitively hold on to and make useful. So I think it's for someone whose brain has been damaged by stimulants, it's a very simple and clear and tangible rationale for them to hold on to.
Wonderful. Thank you so much, Dr. Rawson. I think that was all the questions. I do see people connecting with each other, which is wonderful. And Dr. Rawson provided his emails as well. If you have additional questions, again, the recording of the webinar and the slides will be posted in the online portal so you can access and share those with other staff as well. I think that wraps us up for this Friday. A great appreciation, Dr. Rawson. Thank you so much for joining us and walking us through contingency management. We very much appreciate it and your time. With that, I'm going to end the webinar. Yay. Thank you.